In this episode of Blood and Cancer News, hepatocellular carcinoma rates are on the rise in rural America, and risk factors for severe immune-related adverse events have been identified. This is Blood and Cancer News from MDedge. You can contact Blood and Cancer News at podcasts@mdedge.com. We begin with our top story. Immune checkpoint inhibitor therapy does not increase the risk of developing COVID-19 or the risk of dying from COVID-19. This is according to the results of two studies that were presented at the 35th anniversary meeting for the Society of Immunotherapy of Cancer, or CSIT. According to research published in the Lancet Respiratory Medicine earlier in 2020, cytokine storm plays a major role in the pathogenesis of COVID-19. These data have generated concern about using immune checkpoint inhibitors during the pandemic because of their immunostimulatory activity, as well as the risk of immune-related adverse effects. So researchers at Harvard University conducted two studies investigating whether checkpoint inhibitors increase the risk of developing COVID-19 or dying from it. The first study was a retrospective analysis of more than 1,500 patients with cancer who were prescribed immune checkpoint inhibitors and more than 20,000 cancer patients who did not receive checkpoint inhibitors. The incidence of COVID-19 was 1.4% in patients who received checkpoint inhibitors and exactly 1% in patients who did not. In a multivariate analysis, patients who received checkpoint inhibitors did not have a significantly elevated risk for developing COVID-19. However, the risk of COVID-19 was significantly increased for female patients, those who lived in an area with higher COVID-19 positivity rates, and among those who had severe comorbidities. Among COVID-19 positive patients, those prescribed checkpoint inhibitors did not have a significantly elevated risk for all-cause mortality. The all-cause mortality rate was just under 41% in the immunotherapy group and under 29% in the control group. However, male sex and lower income were associated with an increased risk of death in COVID-19 patients. The second study included 25 cancer patients who had received immune checkpoint inhibitors in the year before they were diagnosed with COVID-19 between March and June of 2020. The researchers matched each of these patients with a cancer patient who had COVID-19 but had not received checkpoint inhibitors during the preceding year. 28% of patients who received checkpoint inhibitors died from COVID-19, compared to 36% of patients who had not received immune checkpoint inhibitors. And in a multivariate analysis, checkpoint inhibitor therapy did not predict COVID-19 mortality. That said, the risk of death from COVID-19 increased with age as well as patients with COPD. The all-cause mortality risk was lower for patients who were using statins. Patients who had received immune checkpoint inhibitors had higher platelet counts and higher D-dimer levels when they presented with COVID compared with their counterparts. However, researchers noted that it was unclear how relevant this finding was because all deaths were a result of respiratory failure, not hypercoagulability. Patients treated with checkpoint inhibitors were more likely to die from COVID-19 if they had elevated troponin levels. This association was not observed among patients who had not received immune checkpoint inhibitors.
Go beyond the headlines and hear the full story on Cleveland Clinic's Cancer Advances podcast. It's the medical professionals' trusted source for exploring the latest innovative research and clinical breakthroughs happening in the field of oncology. From the highest profile cancer trials conducted at our research facilities to understanding how they impact your patients, Cleveland Clinic's world-renowned experts take a deeper look. Listen to the latest Cancer Advances episode by visiting clevelandclinic.org/Cancer Advances podcast.
And we move now to the rates of hepatocellular carcinoma. The incidence of hepatocellular carcinoma is on the rise in rural areas of the U.S. This is particularly true among non-Hispanic white people as well as black people. The increased incidence in rural areas is occurring while the rates of HCC began to slow back in 2009 in urban areas. Investigators compared trends in age-adjusted incidence rates of HCC in both rural and urban areas of the U.S. in the period between 1996 and 2016. They drew data from the North American Association of Central Cancer Registries database, which captures 93% of the country's population, while the SEER database samples 18%. The researchers identified more than 310,000 cases of hepatocellular carcinoma, 85% of which were in urban areas. About 75% of patients were male. The median age range was between 55 and 60 years. There were notable demographic differences between the regions, with non-Hispanic whites comprising only 57% of the urban sample, but 82% of the rural sample. The urban sample included 16% non-Hispanic blacks, 10% Asia-Pacific Islanders, and 17% Hispanics. Age-adjusted hepatocellular carcinoma incidence rates were lower in rural areas, at 4.9 per 100,000 population, compared with 6.9 per 100,000 population in urban areas. But when the researchers looked at the average annual percentage changes using joint point regression, they saw that beginning in 2009, the AAPC in urban areas began to slow. The average annual increase in HCC incidence was more than 5% for the period prior to 2009, and 2.7% from 2009 through 2016. The average annual increase in urban areas remained steady at 5.7%. The largest increase in incidence over the course of the study was among rural non-Hispanic whites, with an AAPC of 5.7%. Among urban non-Hispanic blacks, the AAPC rose by 6.6% from 95 to 2009, but slowed after 2009. In contrast, among rural non-Hispanic blacks, the AAPC remained steady at 5.4%. The only group to see a decline in incidence was urban Asian Pacific Islanders, who had an overall decline of 1%. Among all groups, rural Hispanics had the highest rate of age-adjusted incidence rate at nearly 15 per 100,000 back in 2016. Our final story today, the first nationwide study of severe immune-related adverse events among cancer patients treated with immune checkpoint inhibitors, was recently reported at the 35th anniversary meeting of CSIT. The study could help us identify patients who are at elevated risk for these events. The study was presented by medical student William Murphy. Murphy is currently an MD and MBA student at Harvard Medical School. In his presentation, Murphy said that because there is no ICD code for immune-related AEs, it's very difficult to study them at a population level. Most of the current literature around the incidence of immune-related AEs and factors that are predictive of incidence are based on clinical trials and small studies. So Murphy and his colleagues analyzed claims data from a nationwide health insurance plan for more than 14,000 patients who had a primary cancer and who received at least one administration of an immune checkpoint inhibitor between 2011 and 2019. During more than 19,000 years of patient follow-up, 3.5% of patients developed a severe immune-related AE, which was defined as having occurred within 2 years of their treatment and requiring inpatient hospitalization as well as new immunosuppression. The incidence of severe immune-related AEs per patient treatment year was 2.6% overall, which is up from 0% in 2011 and 3.7% in 2016. In multivariate analysis, patients had an elevated risk of severe immune-related adverse events if they received combination immunotherapy as compared with monotherapy. On the other hand, risk fell with advancing age, and risk was lower for patients with melanoma, renal cell carcinoma, and other cancers compared with lung cancer. Sex, geographic region, income, employment status, and comorbidity were not significantly associated with the risk of severe immune-related adverse events. And that's it for this edition of Blood and Cancer. Blood and Cancer News is produced by MDedge editor Jennifer Smith, as well as executive MDedge editor Kathy Scarbeck. This is Blood and Cancer from MDedge.